Okay, so I'm gonna start. Today I'm gonna be talking about the management of shock in COVID-19 infected patients. Much like last week's lecture, I'm trying to gear this towards non-critical care physicians to give you an introduction into the way that we approach shock in these type of patients and in general. All right, traditionally in the 90s and early 2000s, we were gearing towards these goals for early directed therapy of patients that were going into shock. We were looking to make sure that we volume resuscitated to a CVP of 8 to 12, a mean arterial pressure of greater than or equal to 65, a urine output of greater than zero point 0.5 cc's per kg an hour, and a mixed venous oxygen saturation of greater than 70%. A number of these targets are now considered outdated, and we're going to go into the specific guidelines that SCCM has adapted from their surviving sepsis guidelines into formal COVID-19 guidelines. All right. So their first recommendation in patients with shock from COVID-19 is to use dynamic measures as opposed to static parameters of fluid responsiveness. And I'm going to go into a brief overview of what we consider static and what we consider responsive. Dynamic. One interesting thing here is they talk about doing capillary refill time and/or serum lactate measurements as their dynamic measures, which while I agree they are dynamic measures, I don't agree necessarily that they're the best things that we could be monitoring in these patients, especially lactate measurements, which I've found, having reviewed many charts, is that lactate doesn't seem to be the best predictor of the shock in these people. Okay, so the first thing that we want to decide is if the patient is fluid responsive or not, if they're hypotensive. And this is the reason. There's a number of folks which may be what we call preload responsive and/or fluid responsive, where your increase in preload is going to increase your cardiac function to some degree. So what we have to try to figure out is where these people are along this Frank-Starling curve to see if they'll be responsive to fluid. All right. As mentioned previously, static measures that we can look at are CVP and pulmonary artery catheter measurements. CVP was used as a surrogate for your right atrial pressure, but unfortunately it does not really predict your blood volume and does not predict fluid responsiveness. And that's because blood flow is determined by two functions, and that's your cardiac function and your return function. So your cardiac function is determined by your cardiac compliance, whereas your return function can be due to many things. It could be due to your volume, your venous compliance, your venous resistance, and your downstream CVP. So basically, CVP is determined by your cardiac function, but not necessarily your blood volume. And that's why this has fallen out of favor. As you'll see, there'll be a slide later on where I summarize the things that we try to monitor, and you'll see how CVP stacks up to other types of monitoring. All right, pulmonary artery catheter measurements. So this is used to measure different pressures within the cardiac chambers and to look at waveforms. It gives us the ability to measure cardiac output either by thermal dilution or by Fick. Most of the time we end up using the Fick equation. It also allows us to measure a true mixed venous saturation. Most of the time we're ending up looking at mixed venous saturations from central lines, whether that be from an IJ catheter, a subclavian catheter, or a femoral catheter. And a lot of people with COVID-19 are having femoral lines placed in general, seemingly to avoid the risk of dislodging the ET tube if they are intubated, and also to try to stay away from any potential aerosolization if they are not intubated. But you have to keep in mind that those catheters the tips are much further away than the true mixed venous sat, which is measured from your pulmonary artery catheter. So in reality, those mixed venous saturations from those measurements are lower than what's being reported. All right, other things that we can measure with a Swan-Ganz catheter is your systemic venous resistance and your pulmonary vascular resistance. The reason you may want to know your SVR is it's going to give you an idea. If it's low, you have vasodilatory shock, which may suggest that this is distributive shock, whether that be septic or cytokine release or liver failure. If it's not and your index is down, that gives you an idea that this might be a cardiogenic shock. It will also help you determine if it is cardiogenic shock, if it's coming from the right heart or from the left heart, which is not a moot point in these people because there is going to be a subset of people that are developing submassive or massive PEs. And as you can see on the right, that chart there are your normal values for each of the different measurements that you can make with the Swan-Ganz catheter. All right, now dynamic measures. These are the ones that we use in critical care practice. Some of them can be easily adopted by people who don't usually do critical care, as long as you know how to measure them and what you're looking for. So this is the idea of pulse pressure variation. So in general, people look at pulse pressure to see if they think that if it's narrow, it might be cardiogenic or hypovolemic shock. If it's wide, it may be distributive shock. But what's a good marker of fluid responsiveness is the change in your pulse pressure with your respiratory variation. Now, this is best done on patients who are already intubated and placed on mechanical ventilation, where the positive pressure that you're giving them causes a change in their pleural pressures with inspiration and expiration. That change in your pleural pressures is going to influence your venous return. Now, if somebody is hypovolemic, that influence on your venous return is going to be exacerbated. As you can see on the bottom waveform here, where you see the change with the respiratory cycle, you have a big change in your pulse pressure. Now, the number that we usually target to see if somebody is fluid responsiveness is a pulse pressure variation of 13%. If it's more than 13%, that's going to be indicative that the patient is preload responsive or fluid responsive. If it's less, then they are not. Now, the way that you have to do this with a mechanically vented patient is to make sure that you have enough of a swing in your pleural pressure. Now, I don't want to make things too complicated, but there are a lot of folks that we are mechanically ventilating with low tidal volumes, less than 6 cc's per kg predicted body weight. In order to have these markers be accurate, their tidal volume should be greater than 8 cc's per kg. So that I'm not saying that you have to put everybody on high tidal volumes, but if you want to measure this, you should put them on a higher tidal volume while you're measuring it. Now, how do you measure it? Probably the easiest way to measure pulse pressure variation is going to be with an arterial line in place and what's called a flow track. And this is a monitor where you can see the different indices that you can measure with a flow track. It's basically additional tubing you set up to your arterial line, and you can get these measurements on a real-time basis. On the right, you see SVV, that's stroke volume variation. It's basically the same thing as pulse pressure variation. On the left is your cardiac index. The bottom is your MAP. Bottom left and bottom right is your mixed venous saturation. The advantage of your mixed venous saturation here is it's correlated with an initial mixed venous saturation that you measure from the actual blood, and then it can correlate based on that in real time. Now, what's the use of this is going to be limited by how many we have at this point in the hospital. And, you know, if you have to decide when you think this is going to be most appropriate, given the low supply that we have. All right, so this is a review looking at what your predictiveness of pulse pressure variation is. And here you can see it has a pretty good area under the curve of 0.94, 0.88, and again 0.94 in these studies. Okay, so again, these are the limitations of using pulse pressure variation. Spontaneous breathing activity may not be the best form of people to use this. It's better if they're intubated. If they have cardiac arrhythmias, this again is not going to be reliable. And if their tidal volumes are too low. Okay, those are the major things that I think we have to worry about for the patients that we're seeing. All right, another possibility is to do something called the passive leg raise. Basically, you start off your patient on the left panel here at a 45-degree angle. You then switch it to where you pick up their legs and their head is now flat, again, at the reverse 45-degree angle. And what this is it's basically um, an automatic bolus in a sense. You're bolusing fluid from the venous capacitance vessels, which are storing the majority of your circulation. So this is like giving the patient a bolus without actually having to do it. And what you look for is you look for an improvement in your blood pressure, or again, some of these indices that you can have on a flow track. Ideally, the flow track values here with a passive leg raise will give you the most accurate values. But again, we may not have this as much. So you can look at things like blood pressure and see if that improves. The key here is you need to keep them in this leg raise position for 60 seconds before you make a determination of whether you think that they're fluid responsive. Some of this is going to be limited by going into the room and PPE and things like that, but it's something to keep in mind. Okay, IVC measurements. So IVC is short for your inferior vena cava. So this is a direct look at your inferior vena cava going into the right atrium to see if the patient looks like they're volume depleted. And this could be done two ways. You can look at the actual diameter of the IVC. Usually, if you start getting less than 1.5 centimeters, that's pretty indicative that they would be fluid responsive. You can also look at the variation of the inferior vena cava diameter with your respiratory variation. And this is the same idea as before. With the change in pleural pressures, you're going to have a change in your venous return. So what you're looking at here is your collapsibility index. And basically, if this is showing a change of 40%, that might be somebody who's going to be fluid responsive. Right, this is a JAMA article comparing the ability of these tests to determine whether you're fluid responsive or not. And again, as I mentioned earlier, you look at CVP, and out of all the values here, it ends up being the worst. The best overall is looking at your cardiac output with a passive leg raise while they are on mechanical ventilation. But I'll note again, this may be somewhat limited by the PPE. The other things that tend to do a better job here are your pulse pressure variation in patients that are intubated. This, again, may require less going into the room if you can have the flow track monitor near a window. So this may end up being one of the best things that we can try to do as long as we have enough flow tracks available. But that's all going to be based on where we're at from a supply point of view. Okay. So for the acute resuscitation of adults with COVID-19, the Society of Critical Care Medicine is suggesting that we use a conservative fluid strategy as opposed to a liberal fluid strategy. This is a weak recommendation, and this was put out a couple of weeks ago where there was a lot of concern about the patients going into ARDS. And for patients going into ARDS, you want to have a conservative fluid strategy to help with their oxygenation. I really think this needs to be taken on a case-by-case basis because we are having a lot of folks who are coming in and have been persistently febrile for sometimes greater than a week. And obviously there will be a ton of insensible losses like that, and they may be coming in very volume depleted to the point where you do have to fluid resuscitate them. So I think you have to use your clinical judgment here. In terms of what type of fluid are we going to give people if we think they're going to be fluid responsive, they're recommending giving balanced crystalloids, which would be your lactate ringers, as opposed to unbalanced, which is normal saline. Again, I think this is a small point. Whatever you have available to you, you can use. Okay. For patients that have refractory shock that's not responsive to fluids, we're going to want to start vasopressor agents. And again, we want to target our MAP goal of 60 to 65. Where do these markers come? Where does this threshold come from? This is the threshold where we believe that the organs can maintain autoregulation. So you're getting enough blood supply to them to function. So if you have to put somebody on vasopressor agents, which agents do we want to use first? So the recommendation in general is to use norepinephrine or Levophed as your first line agent. This holds true for the vast majority of clinical situations that you're going to get into with patients with shock, and that's going to stand with patients with COVID-19. In terms of studies that have looked at different vasopressors back to back, There really aren't many that are high quality. The only really good comparison that we have in the past is norepinephrine versus dopamine, where dopamine has worse outcomes, and a lot of that is driven by its arrhythmogenic capacity. So in general, SCCM is going to recommend against using dopamine as your first vasopressor agent. Okay, so if you're refractory to one pressor, or you're starting to go up on your pressor requirements, what do we give? In general, the SCCM is recommending doing vasopressin as a second line agent. And if you see here, they also recommend adding it on as opposed to titrating norepinephrine, which is very vague, but I'll tell you what I think they mean by it. In general, once your levofed requirements start going above 5, and especially if they start going above 10, the incidence of atrial fibrillation increases drastically. So the idea is to put vasopressin on earlier to try to decrease the incidence of atrial fibrillation. Okay. The second recommendation here, for patients with COVID-19 and shock with evidence of cardiac dysfunction, then they're going to suggest adding an inotrope like dobutamine. All right, now I'm going to go into the forms of shock which we're seeing with patients in COVID-19, and you'll get an idea from the cases that I'm going to show you when you would want to start vasopressin and when you might want to start dobutamine. This is a summary of the receptors that our vasopressor agents and inotropes act on. As you can see, norepinephrine is alpha beta, whereas phenylephrine or neosynephrine is alpha. Some people suggest if you're having refractory tachycardia, you may want to move from norepinephrine to neosynephrine to try to decrease the tachycardia. There's no great evidence that this makes a difference, but it's something that could be considered. Epinephrine, again, has alpha 1 beta 1 beta 2. Vasopressin is just vasopressin. Dopamine here, a couple of important points. If you're using less than 5, you're only getting beta 1. Okay, it's not that great a pressor at that point. When you go higher, then it becomes more of a vasoconstrictive agent, but again, it's going to increase your arrhythmia potential. One thing that I would note here when you're talking about inotropes with dobutamine and milrinone, keep in mind a vast majority of patients we're seeing, if they are this sick, are having renal dysfunction, and milrinone will build up and have more potential hypotension, systemic hypotension, once that builds up as opposed to dobutamine. Okay, so for patients with COVID-19 and refractory shock, and usually when we define refractory shock, we're talking about patients that are on 2 or more vasopressor agents. They're suggesting doing low dose corticosteroids. Basically, this is stress dose steroids. And the dose is hydrocortisone, 200 milligrams per day, whether that be as an infusion or an intermittent dose. Most of the time, we end up doing intermittent dosing. In general, in critical care, we do 50 Q6. I think we have to consider Q8 dosing at most, just to decrease the amount of time that people are going into the room to administer this. All right, so the types of specific shock that we're seeing in COVID-19. We're seeing septic shock. We're seeing something called the cytokine release syndrome. And we're also seeing different forms of cardiogenic shock. All right, cytokine release syndrome is excessive inflammatory cytokine production in these patients with this viral infection. And what happens is these excessive cytokines lead to distributive shock, which basically looks like SIRS or refractory septic shock. And you also get direct organ dysfunction, liver dysfunction, kidney dysfunction. Obviously, you get some encephalopathy and refractory shock. And this is a retrospective review from China looking at interleukin levels that were elevated in patients with non-severe versus severe COVID-19 infections. And as you can see, TNF-alpha, IL-6, IL-8, and IL-10, as well as IL-2, were all significantly elevated compared to non-severe patients. Of these cytokines, IL-6 is one potentially that we can try to reverse with tocilizumab. Okay, this is another diagram showing you the pathophysiology of CRS in COVID-19 infections. And as you can see, in the uninfected individual, you got nothing. In the moderate patients, you start to see the macrophages producing these inflammatory cytokines. And you have the CD4 T cells, which are expressing interferon gamma to some extent. And this is important. As you look at the right panel here, you have these increased cytokine levels that are now in this swirling storm. So you just have an excessive amount of production. What you end up developing are symptoms such as ARDS and shock. What you also see here is that your lymphocytes start decreasing your expression of interferon gamma. And we're seeing a lot of this, I think anecdotally in our patients, is that they seem to have some T cell mediated immune dysfunction. We also see that there's a high incidence of severe COVID-19 in patients with diabetes, which is another T cell mediated immunodeficiency. My theory here is you have decreased T cell, cytotoxic T cell immunodeficiency, can't fight the virus, and the body is trying to compensate by increasing these cytokine levels to a dangerous level. Okay, as far as what does SCCM recommend, at this point, even though we have medications to antagonize the IL-6 production, there's insufficient evidence to issue a recommendation on tocilizumab, which is fine. We have no randomized controlled trials looking at this in COVID-19, so I think that's fine. We have been using it for our patients who we suspect are critically ill from cytokine release syndrome. And this is our latest iteration of our criteria. Now, as you can see, you must meet 3 or 4 criteria. You need to have this form of respiratory insufficiency, and you must have at least 7 days of onset of symptoms. Now, the 7 days is coming from the idea that if you potentially give tocilizumab too early, you may actually be promoting the viral replication, because it's the T cell mediated deficiency that is the problem, and you're having this increased IL-6 production trying to increase your T cell maturation. Now, if this is the case and you blunt that, you may have worsening infections. So at this point, we don't know the exact time that it's safe to give this, but we're saying at least 7 days from symptom onset. And what we're gonna do is you order your CRP, which is a downstream surrogate for IL-6. D-dimer, you're gonna send out the IL-6, which goes to the Mayo lab and has a turnover of at least 3 days or so. You're going to get an ABG, VBG, and a T-spot. T-spot is just to make sure that you don't have latent TB. Okay, so some laboratory parameters that are indicative of this storm are your rapidly increasing CRP, ferritin, and D-dimer. And then there will be a multidisciplinary decision between the patient who is taking care of them from a critical care perspective and with the ID attending, and these conversations are had at least once a day. Okay, so those are your septic and your cytokine release syndrome. Before I move into cardiogenic, if you do have somebody who has refractory septic shock or SIRS, you do also want to keep in mind that they may have secondary bacterial infections. So based on what you're seeing clinically, you may also want to start antibiotics and do cultures to make sure that there's no superinfection. Okay, so moving into cardiogenic forms of shock. So this is a real case that was recently published in Circulation. It's actually a nice journal, as you see, a nice article on the bottom that reviews 5 different presentations of cardiogenic, or I should say cardiac involvement with COVID in patients at Columbia. This is one of the cases here where the patient presented with new EKG changes. And you can see there is pretty diffuse ST elevations. The patient was brought to the cath lab after troponins were found positive. They did a left heart cath, which showed non-occlusive coronary artery disease. Right heart cath showed a right atrial pressure of 10, pulmonary artery pressure of 30/20, and a wedge of 21. Echo showed RV dysfunction as well as LV dysfunction. The cardiac index was 1, the EF was 30%. And if you look at the peripheral markers here, lactate was 5, ferritin was 967, CRP was 54, and the D-dimer was, in this case, only 166. A diagnosis of myocarditis was made on this patient. A intra-aortic balloon pump was placed, and the patient's cardiac output improved. And with continued supportive care, the patient actually did survive and was able to be taken off of the balloon pump. Okay, so again, this is a case of COVID-19 induced myocarditis. Okay, this is another patient who presented with severe ARDS and severe ARDS requiring VV ECMO. Once the patient was cannulated for VV ECMO, the patient went into refractory vasodilatory shock. The lactate was 5.1. The patient had an unmeasurable CRP, a ferritin of 4420, and an IL-6 level, which was 331. They did an echo, which shows here apical hypokinesis, which is consistent with Takotsubo's cardiomyopathy. And this was diagnosed as a septic or SIRS-related cardiomyopathy from cytokine release syndrome. So this is an important distinction between the two. One was due to viral myocarditis. The second was an actual septic cardiomyopathy. And it's a little bit difficult to determine what the difference is. And obviously you'll be consulting cardiology at this point. Some ways to try to make this determination are your EKG changes. If you have diffuse ST changes, you want to consider pericarditis or myocarditis. If your echo is showing global hypokinesis, you're going to want to think potentially that that's a myocarditis. If you have apical hypokinesis like this, and potentially ST elevations, then you're going to want to consider a Takotsubo's or septic cardiomyopathy. Okay, another form of cardiogenic shock that you may see in these people are a massive PE. We're seeing very high D-dimers in these people. Anecdotally, I've been following autopsy listservs, and there's been about 30% of patients which have some evidence of clotting. They're not all large vessel, but they may be microvascular thrombosis in the lung. But I think we are going to see a bunch of people who have pulmonary emboli from COVID. Now, they will go into cardiac shock once the pressures in the pulmonary vasculature become to the point where the RV starts to fail. This can be determined by looking at bedside echo, where normally you should have the RV very small, the LV should look circular, and what we're seeing here is we're starting to see the pressure in the RV build up. It's pushing the septum towards the left side of the heart. When this becomes very drastic, it can start to obliterate the left side of the heart, and that's when you start to go into shock. Now, this is the type of patient, this is the one exception to giving Levophed as your first pressor. You may want to consider giving vasopressin in someone like this, because it tends to have more of a pulmonary vasodilatory effect than the other vasopressors. But again, until you have this information, you're probably starting Levophed, but this is just something to keep in mind. Obviously, this is someone that you're going to give TPA to try to reverse the cardiogenic shock from the massive PE. Okay, and this is just for anyone who wants the slides later. I left this as a summary of also some of the other cardiogenic presentations and what to think about when you're seeing people that you think are in cardiogenic shock, and some therapies that might be available for these patients. Again, this is going to be in conjunction with either a cardiology consult, and most of the time also with a cardiothoracic surgery consultation. Okay, so at this time, I'll take some questions. We have about, let's say 5 minutes before we go into the next lecture. I'm gonna do it via chat, I think is the easiest way. So our first question is, will there be time for questions? And the answer is yes.
Jared, can I interrupt for a second? I'm sorry, I had technical difficulties in the beginning, so I couldn't introduce you or the other speakers. But so for the people who are expecting hypoxia as the primary discussion, it is happening with the case next, and Jared talked about shock, so just hang in there. If you thought you were going to be talking, we were going to be talking about hypoxia. So Jared.
Okay, so I have a question. It says, Dr. Body created a protocol for the echo text for COVID-19 patients. They are getting limited views. I guess it depends what you define by limited views. I think even with limited views, you should be able to see whether there's a global hypokinesis or an apical hypokinesis, but I don't know the exact protocol, so I would defer to Dr. Badian.
This is Sabah. Hi, can I comment on this? Just
Yeah.
Okay, great. So we do have a limited protocol in place, and the main question in these patients is going to be left ventricular function, right ventricular function in size, as well as cardiac diffusion. We're able to get all of that within less than 10 images. And so please write on their COVID ICU patient limited, but we're going to do that anyway, even if we don't write that. If there is a patient with aortic stenosis or a severe valvular lesion and we need to do extra images, we'll take care of that. We'll customize the protocol. But none of the patients are going to get complete echoes. We also are able to give definity contrast if needed. So when you say they're limited, it's just the number of views. It's not necessarily the quality.
Okay, understood.
I was the one who asked if you were going to take questions. It's Jeremy Grayson. I'm one of the anesthesiologists.
Hi.
From looking at all the studies and the data that I've been looking at, as far as whether or not this is indeed ARDS and some of the other parameters that are available as far as blood work and stuff goes, from the pressor standpoint, to me, Levophed seems like it's going to clamp down. It's going to give us a number that we like to see, but OR experience shows me and most of us that work in the OR that when you're just giving Levophed and increasing doses, it's at the benefit of seeing a number that we like, but at the detriment of actual organ perfusion in a lot of ways. So I understand that you said that dopamine wasn't great, but from my experience doing pediatric hearts for a long time, epi and dopamine seems to me like it may be a good combination, in so much that epinephrine at beta doses is going to help contractility and also help with vasodilatation in the pulmonary beds, helping forward flow from the right side of the heart. And then from there, you plus or minus add milrinone. And we do that in a lot of patients who are, you worry about the hypotension per se, but if you start it low, also helps with contractility. Because if the lungs are stiff and the compliance is not great, when you increase flow and you increase preload, you're going to back up. So
I can't speak to the pediatric population. And like I said, the back-to-back doser.
It holds for adults also. I mean, I've done adult hearts as well, and taking care of critically ill adult patients also. I just think that the Levophed is not necessarily helping.
Yeah, so like I said, there's no back-to-back high-quality vasopressor studies in general in critical care.
Yeah.
All I can say is that most major critical care societies will recommend Levophed as your first dose vasopressor. And I think for general practitioners who are being thrust into the ICU, I would still say starting with Levophed is the best way to go.
So when I asked this question yesterday to Dr. Carson and some of the other people that are involved at high levels, as far as making changes to protocols, we're kind of hamstrung to an extent, correct? Like, if I were to be one of the ICU attendings next week, would I be under the right to use epi and dopamine and use low tidal volumes, go down on the PEEP instead of up on the PEEP, and see what my outcomes were like?
Yeah, absolutely. I think for anybody who's, obviously trained in critical care medicine, you use your, best idea of what's things going on. For the general practitioner who's being thrust into this, then I think protocols are very useful. But if you see clinical scenarios where you think it's better to use other agents or your titration of your PEEP strategies is a little bit different, I think that's fine.
Okay. And then as far you said something early on about the CVP and using femoral catheters in the mixed venous sats. The mixed venous sat from the IVC is going to be higher than the mixed venous sat from the SVC, because the SVC is draining the brain, which has a higher extraction of oxygen. So your IVC measurement from the CVP is going to actually be lower, is going to be higher. Usually have like a mixed venous sat under normal circumstances coming back from the IVC at about 80 to 85, 80 to 85. And from the top, it's going to be 70 to 75 from the SVC.
Right, and but the point is both are going to be surreptitiously high than what your real true mixed venous saturation is, and that's kind of the point.
Okay, all right. Thank you.
No problem.
And then questions about like hemoglobinopathies is the next lecture?
At some point, yeah, we'll do hemoglobinopathies, but I wouldn't worry about it right now.
Okay, but today or no? I'm just
No,
curious.
not today.
Okay.
Okay, if no one else has any questions, then we're going to move on to part 2. All right.
So part 2 is a lecture, is actually Sarah's made a presentation on the various manifestations of hypoxia in these patients and what needs to be considered, and that not all patients appear to have the same phenotype of hypoxia. So it's going to be Sarah Orfanos, one of our fellows.
Hello, everyone. I'm Sarah. So before I start the lecture, I wanted to continue the tradition that, can you hear me? I
Yeah.
think so. The tradition that Kathy started. So what's happening on the front lines, as we say these days. So we have Kareem, who is a very strict nun on a keto diet, who started eating donuts. And that's when I realized that there was a crisis going on. And then we've been stretching. We've been stretching around the hospital and drinking bubble tea, and we also been taking around the hospital. It's nice. You can press next. And then we've been taking walk around the hospital, and we've been exercising and dancing in the hallway. Hold on. Okay. Anyway, it looks like my pictures are gone. So let's start with the presentation about the timing of intubation for coronavirus patient. So 3 weeks ago, I know when the crisis started here, we were saying 6 liters nasal cannula, and you need to do early intubation. The problem is that right now, what's coming back from New York, Italy, and China is that maybe that was the wrong management, and we shouldn't do early intubation on these patients. And the reason why is that on the next slide, there's not just one phenotype of coronavirus. If you can go to the next slide. There is many phenotypes of coronavirus. The main phenotypes that we see in the hospital and in the ICU right now. One that we've seen a lot of coronavirus patient right now, we've seen it a lot also, is a silently hypoxemic patient or the happy hypoxemic patients. So this is basically the patient who come in with a saturation of 70%. You go. Can you go back to the slide with the phenotypes? Or can I do it? And then the slide before that. So the silently hypoxemic patient, the patient who comes in the hospital, patient of 70%, and who is asymptomatic, so it doesn't have any end organ damage from hypoxia, so it doesn't have any lactate, no tachypnea, no tachycardia, no increased work of breathing. They're just sitting in their bed with a saturation of 70%. And I know we've seen a lot in the hospital, so that's why I wanted to focus on these people. The other phenotype that we've seen also is a hyperacute patients, ARDS patient. Usually these patients are the one who come with severe hypoxemia, who's very symptomatic, who gets intubated in the ED, and then usually has a pretty bad prognosis. And then the indolent patients is more or less stable, but at day 5 of symptoms, day 5, 6, or 7, starts having hypertension, supraventricular tachycardia, high fever, and a rise in inflammatory markers. And these patients, if we intubate them before the rise in the inflammatory markers, they often get re-intubated. So the pathophysiology that was to try to explain this hypoxemia. So we're not sure yet, but there's a lot of hypotheses. The first one is that because this patient is so hypoxic with a normal PCO2 and a normal minute ventilation and no increased work of breathing and no response to oxygen, we think that they have a shunt-like physiology. And also this patient, we can see a discrepancy between the CAT scan, which shows some ground glass, but not terrible, but a very profound hypoxemia. So we think that they have an absence of vasoconstriction in response to atelectasis, which is going to worsen the VQ mismatch. We also think that they might have some microthrombi. So we already talked about it last week, starting anticoagulation for high D-dimer. There's no data about it yet, but I know we're trying that in the ICU. And then for the happy hypoxemic patients, so the patient just sitting there on saturation, there might be some neuro involvement with a decrease in the hypoxic drive.
Sarah, can I interrupt for a second? Can you please go closer to the mic? People are saying they can't hear you very well. Sorry.
I don't know what the microphone is. Okay, can you hear me now? Can you hear me?
Yeah, better. Just it seems like you fade in and out. That was the problem.
Okay, so the next slide. So here you can see on the left alveoli there's an atelectasis of the alveoli, and usually your body responds by doing vasoconstriction so that the alveoli that is not ventilated is not perfused. But in this COVID patient, we think that this doesn't happen, so they still have a high blood flow going through non-ventilated area, which is so a worsening VQ mismatch. So the question is for this happy hypoxemic or silently hypoxemic patient, so the patient sitting at 70% of saturation without any symptoms, are we intubating them too early? So the data that came back from Europe and China are now starting to say that maybe we're intubating too early, and actually Italy, we all know that Italy had a lot of cases, but also a lot of deaths, and they don't have a worse healthcare system than here. So the way they explained it is that they maybe at the beginning of the crisis, they intubated way too early and they ran out of ventilator. And also these people who are happy hypoxemic, they might do worse once they get intubated. So the next slide. So how do I decide if these patients need intubation? So you can't base that decision on the saturation because the saturation is going to be low, and because there's no end organ damage from the hypoxia, you don't really need to raise that saturation. And also you can't base it on the tachypnea also because they're asymptomatic. So the way you decide is that on the work of breathing, so not just the respiratory rate, but also the use of accessory respiratory muscle. But most importantly, you based it on the altered mental status, because I'm sure the people who take care of the COVID patients notice that these patients, even though their saturation is very low, they're less confused than you and me. And then the last thing, but we don't get ABG all the time, is that these patients usually have a low PCO2. So if you have a high normal or high PCO2, then you should start to worry and think about intubation. Next slide. So how do I manage before intubation? So it's like every patient, we start with nasal cannula, and then you can move on either to non-rebreather 15 liters. And if that's not enough, you can do nasal cannula and non-rebreather both at 15 liters and put on a surgical mask on top to limit aerosolization. Or you can try the high flow with a flow of 40 liters per minute. The best technique is actually CPAP, but in the hospital, I think we can only use it in negative pressure room. And then these patients, you're gonna ask them not necessarily to be prone all the time, but you're gonna stick your head in the room and tell them, go on your belly, 2 hours later, left side, right side. So that's what we call the pig roasted technique. And then these patients, even though they have a saturation of 85%, you're going to tolerate that saturation because, as I said before, they don't have end organ damage from this saturation. So the reason why CPAP is the best technique, so in Italy, they're using this helmet that we don't have here. But I think you can use it in a negative pressure room, and it's only aerosolization, it's only when there's a leak on the mask. So the reason why it's the best, because it has the highest pressure, so it's going to improve recruitment of the atelectatic area of your lung. So usually you started with, you go as high as 15 or 18 of PEEP as tolerating, and usually as you recruit the alveoli, you can go down on the FiO2. Next slide. So if you do have to intubate your happy hypoxemic or silently hypoxemic patient, they are actually very different from our ARDS patients. So what we noticed in the ICU is they don't have high plateau pressure and they have normal compliance. So we can really apply the algorithm on ARDS that we use usually with low protective ventilation with low volume and a high PEEP. So on this patient, we use an intermediate volume, so 8 ml instead of 6, and we can use higher FiO2 in order to not use too high of a PEEP. If you do try to do ARDS net on these patients, they usually have a lot of asynchrony, and then we have to go really high on the sedation, use paralytics. So that's why the best mode for the vent right now, that's what it's being said, but it might change next week, is APRV. So next slide. So on APRV, you're gonna set true pressure, a P high that the patient is gonna spend most of his time at, and then a P low to enable for CO2 exhalation. And then ideally you want the patient to be spontaneously breathing. Next slide. So the advantage of APRV is that we saw this drawing before. So we're going to recruit the atelectatic alveoli where the vessels are still dilating in the coronavirus patient. So even though they don't have that much atelectasis, we're still going to increase the PO2 by a lot just by recruiting these alveoli. The other advantage on the next slide is that we can enable the patient to be spontaneously breathing. So when he does that, he's going to work his diaphragm and he's going to ventilate the dependent areas of the lung. And as we know, the dependent areas of the lungs are the most perfused one. So you're going to be able to fix the VQ mismatch. On the next slide, we can see a CAT scan of a patient on APRV. On the left side, the patient is spontaneously breathing, and on the right side, the patient is sedated. So you can see that when you're spontaneously breathing, because you work your diaphragm, you're able to recruit the dependent areas of your lung. So I did a couple of slides because the residents are working with us a lot, and to try to help them with these patients who are going to be on APRV. So they're gonna have to set 5 settings on the machine. So a high pressure that is usually around 30, so 25 to 30. And then a T high, so this is the time that you spend at the high pressure, which is gonna be pretty long, so 4 to 5 seconds. So when you divide like 1 minute, so 60 by 4 or 5 seconds, it's a rate of 15 or 14, I think. And then you're gonna set a low pressure, which is usually at 0. And they're gonna spend very little time because you don't wanna lose your recruitment. So 0.4 seconds at the pressure of 0. And then on top of that, because the patient is breathing spontaneously, each time they take a spontaneous breath, you wanna add some pressure support. So usually 5, because when you think about it, if your PI is 30, you don't wanna go too much higher because you're gonna be at 35 when you add the pressure support. You also don't wanna lose the benefit of spontaneous breathing, so you're gonna aim for a RASS of 0 or -1. Next slide. Once your patient improves, so also on APRV, don't stress out in the first 2 hours because it's gonna take like 4 or 8 hours to get, for the ABG to get better and for you to recruit your alveoli. So I would recommend waiting a few hours before you switch the mode again. Once the patient gets better, your goal is to switch your PRV to CPAP. So your P high is going to become your continuous positive expiratory pressure. So you're going to drop your P high by 2. And then 2 hours later, come back, check the saturation. The saturation is good, then drop again by 2. And as you do that, you're going to expand your T high so that then you have a continuous pressure. If the patient is still hypercapnic, you can help them by adding some pressure support. So instead of switching your APRV to a CPAP because you add pressure support, it's like switching to pressure support or BiPAP mode. Next slide. Once your patient has a FiO2 of less than 50% and a P high of less than 18 with a T high of more than 10 seconds because you've dropped the P high and extended the T high, then you can think about spontaneous breathing trial. The only thing about that in this coronavirus patient, if they have increasing inflammatory markers, it has been shown that there's a high rate of reintubation, so maybe don't extubate if you have this happening. Next slide. The additional therapies that we've been doing in the ICU, for the silently hypoxemic or happy hypoxemics, they're very responsive to proning. So if your PaO2 FiO2 ratio is less than 150, you should prone them. So for that, you need to switch them to volume control, and most of the time you need to paralyze them. I know in the ICU we've been trying nitric oxide. We could try nebulized milrinone. I'm not sure about the pathophysiology and why it's gonna help, but I know we've been trying that in the ICU. Next slide. So the problem with this phenotype of the happy hypoxemic ARDS patient and indolent patient is that sometimes the patient switch category and go into another phenotype. So that's why we ask our residents and ourselves to check the plateau pressure every day. And if the lung become less compliant, then you should switch to the ARDSNet algorithm. Next. So in conclusion, the message that I wanted to give is that there's not just one phenotype. We've been seeing around the hospital a lot of happy hypoxemic, silently hypoxemic patients. And we can actually delay intubation in this patient if they don't have any sign of end organ damage, so confusion, and tolerate a saturation around 85%. The goal is to improve alveolar recruitment. So if you can do CPAP, do CPAP, otherwise high flow or non-rebreather. And then when we intubate, we should put them on early APRV. Thank you.
Thanks, Sarah. I'm going to, in the next 5 minutes, discuss some of what Sarah mentioned, because the management of these patients based on the phenotype that we are seeing seems to vary depending on the pathophysiology. So there are the group that come in that are hyperacute, like Sarah mentioned, that go into frank ARDS right from the get-go, who appear to be extremely PEEP responsive, who appear to be very responsive to prone positioning. I would push back a little on the discussion on APRV, honestly, because I'm a little concerned that if we take home the message that everybody who's a happy hypoxemic should go on APRV, the very concerning part is a couple of things. One is that if they have high compliance and they're not very, which indicates that they're not very atelectatic and there's not a lot of alveolar filling process, then why are we using very high speed, hyper-recruiting them, especially if they're hypercapnic? Because if they're hypercapnic, APRV would just make things much worse. So we got to be very careful about how we manage these patients. So I think that this is, again, a learning curve. We're all trying to figure out what's the best management strategies. And I would argue that based on the initial blood gases, if you see severe hypoxemia, hypocapnia, shunting, then prone positioning, volume control ventilation with low tidal volumes is the best way to go. If you see hypercapnia, on the other hand, like Sarah mentioned, I would actually go for a slightly higher tidal volume, low PEEPs, and give fluids, because that's an indication of dead space ventilation. I wouldn't do APRV. I would actually argue against it, because that would actually worsen the hypercapnia. So those are my thoughts on this. Again, I think the phenotype changes depending on what the pathophysiology is, and unfortunately, I don't think we fully understand it. Um, the so two things that seem contradictory. One is that we're saying maybe they have impaired vasodilatory mechanisms that leads them to have shunt-like hypoxia. Well, in that situation, you should not have hypercapnia. You should be hypocapnic and severely hypoxic. On the other hand, if you're saying there is microthrombosis, that's a situation of dead space with hypercapnia. So got to be very careful about not mixing the two. One of the things that wasn't discussed is why are they happy being so hypoxemic and not dyspneic? And is there a central control issue where their hypoxic control is affected and impaired, and maybe they don't have the usual hypoxic ventilatory responses that we see when your PO2 drops below 60 or your SATs drop below 89, something that we still don't understand as well. There is a degree of encephalopathy in these patients, and whether that's and some demyelinating processes have been described, whether that's affecting the brainstem centers and whether the carotid body is affected is again issues that we don't understand fully. Another mechanism of hypoxemia that has been described is an impairment at the cellular level of the transport within hemoglobin of oxygen in this particular population. So there are different mechanisms of hypoxemia. I think the important thing for the COVID teams on the floors is the fact that you could potentially increase oxygen levels, go to non-rebreather, go to high flow oxygen with a low flow amount of oxygen, keep a surgical mask on these patients, don't, and if then they are not doing well, to consider intubation. Again, look at the inflammatory markers, trend them because they seem to correlate well with the patients who go into severe ARDS. And if you see very high early inflammatory markers with alveolar filling process, these people need to be intubated early.
So when you're talking about the VQ mismatch, to me, it seems like there's some sort of impairment of hypoxic pulmonary vasoconstriction. And it means to me that the vessels should be clamping down in the areas that are not getting ventilated, so that they're not ventilating the air, those diseased alveolar segments. So by virtue of that, you mentioned the hemoglobin thing here, and recruitment issues. So when you have the patients that are on the floor, do we give them incentive spirometers to practice deep breathing exercises that may help them on their own? Because I find that if you do like deep breathing by yourself and blow out through pursed lips, you're kind of simulating an auto PEEP to yourself that's helping stent open your lungs. And I don't know if that's something that we've tried with them.
Yes, and the short answer is yes. We've been actually asking everybody to do incentive spirometry. The progression of X-rays is very interesting in this population. So you start with this very peripheral looking infiltrates where a pneumonitis that's classically described in the COVID population of, a density that's in the periphery of both lungs, and in fact reminds me of the chronic eosinophilic pneumonia patients where you have a negative bat wing appearance. However, as they get more hypoxemic, you start to see more central infiltrates, but very peribronchial or bronchial in their nature, with air bronchograms in the proximal areas, very suggestive of mucus plugging. These people complain of chest tightness, they're hypoxic, and they have silent chests. So my feeling is there's a lot of mucus incipation with a lot of thick mucus that they aren't able to bring up that makes them more hypoxic, leading to the VQ mismatch, leading to hypoxia. So if people remember in the old days, status asthmaticus patients who died, if you did their autopsies, you found extensive mucus plugging in the airways. I believe the mucus plugging is very peripheral in the airways. That's why you don't see or hear the wheezing, but you just the silent chest that you're hearing. And I'm not sure if the stretch receptors are activated enough or the hypoxic sensors are adequately activated to cause them to be significantly dyspneic. That's the point where I believe strongly that Unfortunately, in this population, because of the concerns for aerosolization, we're just using MDIs, not using nebulizers, not giving them humidified oxygen. And therefore, they're getting more and more hypoxic, unable to get rid of that mucus hypersecretion. Unlike what you would do in a patient with classical bronchiectasis or CF, asthma exacerbation. And so then they end up after that process in about 5 to 7 days. I think there's lung injury from all the pleural pressures they're generating to try to overcome that mucus hypersecretion, leading to this ARDS-like picture. That's the sense I get of the progression of this illness from the floor patients that I've been seeing and the ICU patients. And therefore, the pathophysiology clearly is different depending on where you catch them in their hypoxemic process.
Yeah, Senda, I'd like to make 2 points on that question too. The first about hypoxic vasoconstriction, that only works if you have patent vessels. There's a lot of anecdotal evidence here that there's a large degree of microthrombi. So you may not have a perfect compensatory vasoconstrictive response if the ones that are dilated are obstructed with clot. The other thing about improving perfusion to the lung is we've been doing a lot of self-proning on patients who are not mechanically ventilated, and that itself will create a more homogeneous distribution of blood to the lungs. The second point I wanted to make is that in terms of APRV, nobody should be started on APRV from the get-go without a pulmonary consultation. If the patient truly has ARDS, which the autopsies that I've been looking at from around the country suggest they do, the potential risk of APRV is high, because if you remember from my lecture last week, that potentially will increase your transpulmonary pressure even more, potentially leading to increased lung injury. So you really have to make sure that you're not dealing with ARDS before you decide to do APRV as a first modality. I think there is some role for APRV from indirect lung injuries, but COVID-19 is a specific lung injury from a respiratory virus, and we have to keep that in mind.
So in the chats, we're getting a number of questions and the role of steroids and anticoagulation. My thoughts on steroids, I can quickly give you that. Again, on the consult service, we've been seeing this, Dr. Arora last week and myself. I think there is a role for steroids after about a week of the illness or beyond, where then you start to see an increase in inflammatory markers. And at that point, a more diffuse bilateral process, not the impression of mucus impaction, where I think there is early lung injury. And at that point, steroid seems to make a difference. And I've been using Solimedrol 40Q8 on these patients. In terms of anticoagulation, we just came out with a protocol for anticoagulation on all the floor patients, and that recommendation was made with the hematology consultants on board. Their feeling is that the D-dimer rise is kind of late in the process. They feel that this is the whole COVID illness is a hypercoagulable stage, that the fact that the D-dimers at the get-go are rather high. You don't see, you see D-dimers in the 300, 500, even early in the illness, and they feel like just following the D-dimers and then seeing them suddenly shoot up, maybe missing a group of people who have already developed microthrombosis, and that anticoagulation, therefore, from prophylaxis to escalation to a full dose should be done more on a clinical basis. What that clinical indicator should be is a very difficult question to answer. We did put in some parameters of hypoxia. I'm not sure that's the right answer, but we don't have any other clinical parameters to go by.